Good morning, sir.
Yes, very good morning to all. Yes, so today we'll be completing the main part or the clinical part of stroke. Yes, so we were discussing on the motor aspect of the stroke and we had discussed so far the six points. Now coming to the last and most important point is disturbing postural control and balance. We saw some part of it in the motor aspect itself, in the tone of the muscle. Moving forward, impairment in steadiness, symmetry, and dynamic balance. Steadiness, that is ability of an individual to maintain a specific posture. Yes, so they cannot remain steady. They will continuously move and try to adjust their posture. Symmetry, as you know, one part of the body or one half of the body will be affected. So when you look at the patient, you directly say the symmetry, that is shoulder levels at the same level, elbow wrist level, even the pelvic level will be altered because of the change in the posture. And dynamic stability also, whenever the person is moving or changing posture, at that time also the stability changes. Why is it important to us? It is important because whenever the patient is trying to maneuver or even trying to maintain a specific posture, there are chances he or she will fall. And as a physical therapist, you should be there whenever of course the patient is coming to you, or you are going to the patient at their home or any specific hospitalization IPD. At that time you need to take care what all things, if the patient is not having good posture and balance, then it is our job to maintain that while he or she is performing few activities or exercises. Second, problems with reactive postural control and anticipatory postural control. Now reactive postural control is actually while performing or maintaining a specific posture. Second is anticipatory postural control, that is to anticipate. Anticipate is expect. Yes, mentally to be ready. Whenever you think of doing exercise, your heart rate increases, your respiratory rate increases, yes, blood pressure slightly increases. So these are all anticipatory responses. Same way, whenever you ask the patient to stand, they will not try to understand, or they will not be able to change their normal internal homeostasis. That is anticipatory postural control. And reactive control is while actually performing it. You ask the patient from sitting position he wants to stand. Yes, so this the patient will have problem with. This is reactive postural control, and second is anticipatory postural control. Third, postural asymmetry with most of the weight shifted to normal side. Yes, as we already know, one side will be weaker or completely paralyzed. So patient will not use that side. So more amount of force will be on the normal side. So that will cause again asymmetry. Whenever you are standing, say for example, right side is affected. So whenever the patient is standing, more of the weight will be on the left side. You can see the pelvic tilted on the left side, pelvic drop on the left side. So that is an example of postural asymmetry. Increase postural sway and standing position. So whenever the patient is standing, there will be more postural sway is nothing but adjustment, continuous adjustment what the patient will make to try to maintain the balance, maintain the center of gravity or the base of support. Compensatory response, excessive hip knee movements will be there. Yes, so pelvic you can see will move continuously, hip motion will be there, and knee flexion or complete extension will be there to maintain that posture, to compensate for the weaker side. Hemiplegic patients fall direction of weakness. Normally, patients will not be able to control the motions which are happening on the weaker side. So right side is affected, patient standing or even while in sitting position also they'll try to maintain the posture, but they will always fall on the weaker side, on the affected side. Coming next to from the motor aspect to the higher centers which are responsible for first speech and language disorders. So aphasia, that is inability to speak, acquired communication disorder caused by brain damage characterized by impairment of language comprehension. So it two ways. Either the patient does not understand what you are saying, cannot perceive that, or they will not be able to speak up. Yes, are not able to perceive or if they are not able to form sentences, that is also termed as fluent aphasia or Wernicke's receptive aphasia. If the patient is able to speak but baffling is there, that is non-fluent or Broca's or expressive aphasia. Wernicke's, Broca, yes, they are mainly centers in the brain. Yes, specific part of the brain, regions of the brain, and that is why they are termed as Wernicke's and Broca's aphasia. And if the patient is not able to understand, not able to speak up together, that is global aphasia. Yes, that is combination of Wernicke's and Broca's. Aphasia means acquired communication disorder. Acquired means it is obtained after birth. It is not congenital, not from the birth itself. Yes, acquired communication disorder, cannot communicate better, caused by brain damage and characterized by impairment of language comprehension, formulation and use. Comprehension, that is, you know how to speak up. Yes, you already know. If you are meeting someone, what is the first statement? Say hi, how are you, what is your name? Yes, but if this is lost, patient does not remember how to form sentences, that is language comprehension. Formulation, the same way, how to form sentences specifically. And third is use. Yes, if the patient knows what is to be spoken but cannot still speak up that way, that is use, impairment in use. So language comprehension, formulation and use. Classification, as we discussed, Wernicke's aphasia, Broca's aphasia and global aphasia. Global is nothing but combination of Wernicke's and Broca's. So when there is fluent aphasia, yes, there will be speech. The patient will be able to speak very fluently. Preserved melody, yes. So the tone of the muscle, tone of the choice or tone of the voice will be normal. Yes, according to what, like I am speaking right now. So that is preserved melody. I know when to decrease my tone, when to increase my tone. Third is impaired auditory comprehension. So patient, when you are speaking, hi, how are you, what is your name? Patient, when you are responding to that question, if the patient has asked this question and you are, hi, my name is X and I am your physical therapist today. So the patient will not be able to get it. Yes, that is impairment in auditory comprehension. They will not understand what you are speaking. They know how to speak and understand everything, but they will not be able to comprehend your response or opposite response. So that is auditory comprehension. That is a lesion in Wernicke's area. Hence it is termed as Wernicke's aphasia also. Non-fluent, that is hesitant speech. Yes, it will be limited vocabulary. They will have a very limited vocabulary. In fluent, you can see thus fluent speech is there. Yes, they know complete vocabulary, whatever they have learned. They can use all the words they have learned in the lifetime. But here in non-fluent, they have very limited vocabulary and they speak only words. Yes, hi, name, okay, two or three things you have to understand. You have to figure out what is he trying to express. Yes, non-fluent aphasia. Speech production is labored or absent. Yes, so they require high amount of energy to speak up. Yes, because it is a speech disorder. Speech production is labored or even at absent. Initial phases, the patient will have no speech. Yes, so that is important. You need to understand. In the initial phases, if you are seeing the patient in IPD and he or she is not able to speak up, that means there are chances it will be Broca's or non-fluent aphasia. And comprehension is good, but they are able to understand whatever you speak to them, they will be able to understand. So that is Broca's aphasia. And global, marked impairment of both production and comprehension, a combination of Broca's and Wernicke. So there will be impairment in production also and comprehension also. Indication of extensive brain. So when there is global aphasia, that indicates that large amount or large portion of the brain is affected. Severe problem is patient's ability to even learn. If large damage is there, that means chances of getting language and speech back are also difficult or minimal. Yes. Dysarthria, that is category of motor impairments, disorder caused by impairment in the central or peripheral nervous system that mediate the speech production. Now say for example the patient is normal, patient has normal language and normal speech, but the bones, the muscles, they are not articulated properly, and because of this there will be difficulty in speech production. Yes, so dysarthria means impairment in speech production. Yes, vocal cords, your pharyngeal muscle, laryngeal muscle, hyoidal muscles, all this require to be normal. Your tongue requires to be normal. Yes, the muscles of the tongue, they should be normal. Then only you can produce and speak up things. Yes, if they are not normal, or if they are not articulating, they are incoordinated, then there are chances it will cause dysarthria, that is problem in the speech production. Respiratory, articulation, phonation, resonance, sensory feedback. Out of these five, any one portion is affected. Respiration, yes, while we are speaking, if I'm speaking continuously, I'm taking breaks in between to inhale and exhale. Yes, so this is in role of respiration while talking. Articulation, the bones itself, if they are altered in nature, yes, the pharyngeal, laryngeal muscles are also altered, that is production of phonation. Resonance, resonance, what do you understand by resonance? Can anyone tell me what is resonance? Resonance એટલે શું? Yes, please.
Sir,
Yes.
sir, I exactly don't know, but if we produce a sound in one object, the nearby object also resonates, means together. I don't know properly, but I know one example. Like the army men marching on a bridge, they don't march because it will resonate and it will fall. That's why I don't know exactly.
Yes, I'm so sorry, the connection just went off. Able to hear me?
Yes, sir.
Okay, okay. Akriti, you were saying something. I'm so sorry, I didn't get it. Can you repeat?
The sound produced in one object, resonates the other object, nearby object.
That
Means
is true. That is true. Okay. I'm not able to read your messages though. It is showing blank there. Fine. So resonance is nothing else but a vibration that is felt when you speak things. Yes, it is kind of whenever you speak up few words, the sound is resonating not only in your nasal cavity but also in your chest region. Yes, the best example of it is when you stretch the word om. Yes, when you speak up all the phonations in the om word. Yes, so everyone, uh, you can keep it mute, that is fine. You can try, keep your hand on the chest. Yes, on the chest, keep it on the proximal aspect, and then try to speak up om. Yes, you can feel the whole vibration. You can feel it yourself. You can try it yourself. Feel it right now. Yes, just pick up the word, stretch it to a limit, and you can feel the vibration in your chest also. You can feel the vibration in your nose also. So that is example of what you say resonance. Okay. And last is the sensory feedback. So whenever you are speaking, always there is a loop, that is feedback loop. It will tell cerebellum, it will tell your basal ganglia, it will tell your sensory and motor cortex and the speech producing areas that this is the feed. If you are speaking something else that is intended or that was not intended, then there will be a sensory feedback and you will realize it immediately. This happens in seconds. જ્યારે હું બોલું છું, at the same time there is a sensory loop that is going on that will tell again what am I speaking to the brain. If there is something wrong, it will take care in the future or correct it at present also. Yes, so this is respiration, articulation, phonation, resonance and sensory feedback for an individual. Any of this is affected, that will lead to dysarthria, that is impairment in speech production. Lesion mainly in the primary motor cortex, second primary sensory cortex, and third is cerebellum. Yes, primary motor cortex responsible for all motor movements, including your speech production. Second, primary sensory cortex, which is responsible for what we described in the sensory feedback. And third is cerebellum, which is the comparator of all the sensory and motor tasks. સેરિબેલમ ઇઝ અ કમ્પેરેટર. યસ, તમે કાંઈ પણ વસ્તુ કરો છો પહેલા ઈ સિક્વન્સ બરાબર છે ચેક કરશે. એકવાર મૂવમેન્ટ થઈ ગઈ પછી મૂવમેન્ટ બરાબર થઈ કે નહીં ઈ પણ ચેક કરશે, એટલે કમ્પેર કરશે. ધેટ ઇઝ વાય ઇટ ઇઝ ટર્મ્ડ એઝ કમ્પેરેટર ઓફ ધ બોડી. Last, chewing, swallowing, etc. may be impaired. Now, as the muscles are also impaired, there will be the actions of chewing, swallowing also will be affected. If swallowing is affected, this is termed as dysphagia. So dysphagia is impairment in chewing and swallowing activities. Yes, so what are the reasons why does this happen? So first of all, there will be lesion of medulla involving cranial nerve 9 and 10. Large vessel pontine lesion. Yes, we are going to discuss about the lesions in the region specifically after we complete the clinical features. And acute hemispheric lesion. So any acute hemispheric lesion, large pontine lesion or lesion in the medulla will lead to dysphagia, impairment in swallowing. Yes, normally we are swallowing our own saliva at all times and food when we are having our breakfast or dinner. So it is an important activity. Yes, normal peristalsis we need for the movement of the bolus that we form through the chewing mechanism and swallow later on to move it to esophagus and to the stomach for digestion. When this activity is lost, this is termed as dysphagia. Any portion of chewing or even swallowing, more important is swallowing. It is because of dysfunction of the lips, mouth, tongue, palates, pharynx, larynx, or proximal esophagus. Any of the 7 areas is affected because of the primary motor cortex, medulla, large vessel pontine, or hemispheric lesion. Then it will be causing dysphagia. Now you can see here, dysphagia can be because of delayed triggering of the swallowing. So whenever we require, like I want to swallow my own food that I've just chewed, that is not possible, or I have to start swallowing the exact time when I'm pushing the bolus through the larynx and pharynx downwards. Yes, જ્યારે હું larynx, pharynx and palate માંથી tongue through bolus ને push કરું છું, same time the peristalsis should start and the esophagus should be able to perceive or able to receive the bolus. Yes, so if there is any change in the timing, that is delayed triggering of swallowing, lead to dysphagia. Second is reduced lingual control. So tongue, if it is reduced in function, if it is paralyzed because of any reason, medulla lesion, then it also cause dysphagia, because tongue is at most important. Tongue moves the whole bolus into the mouth as well as pushes it downwards towards the esophagus. Third, reduced peristalsis. So as we talked about, peristalsis is utmost important. So if peristalsis is not there, peristalsis is nothing but contraction and relaxation of the smooth muscles. Yes, so these smooth muscles will be responsible for movement of the bolus. Yes, so if it is lost, then there will be dysphagia. Severe cases may require nasogastric tube for short period. Yes, nasogastric tube. So from the nose to the stomach, a tube can be used, and then food is provided, or liquids mainly are provided through the tube itself for short initial phases only. Invasive gastrotomy tube for long term. Now gastrotomy, that is opening a part of the stomach and keeping it open and directly delivering the food through that part, through the tube. Yes, so that is invasive gastrotomy tube, that is for long term. If the patient is not recovering, if the medulla is affected permanently, there is no way the patient will learn again this how to swallow, then we have to go for invasive gastrotomy tube. And last is intravenous route. So IV route, directly providing the nutrients through IV route, through the pine. Yes, જે આપણે કહીએ in simple language બાટલો ચડાવો. Yes, so that is intravenous route, but that is also short lived. Yes, because there are many complications attached with intravenous route or gastric tube, but relatively gastrotomy, which is for long term, is safer for such individuals who have problem in swallowing or even bolus chewing. Perception and cognition. We have discussed this part, so I'll just name the disorders we have discussed for them in assessment part in much detail. So, lesion of right parietal cortex produce perceptual disorders. This is also what we discussed. Parietal lobe will always be responsible, and non-dominant side mainly, that is right parietal cortex. Three important subtypes: body scheme, body image disorder, second is agnosia, and third is spatial relation. Body scheme, body image disorder, urinatal neglect, one part of the body patient will neglect. Left right discrimination, when you speak the word left and right, the patient will not able to get, but if you show them what they have to do, they will do it very easily. Finger agnosia, not recognize our own or their own finger. Agnosia will be again visual or tactile, that is they will not be able to perceive few things, not they will forget few things, that is they will not understand or get. When you show them a known object, they will not be able to name them, they will not be able to name whose sound it is, that is auditory. And tactile, they will not be able to sense a sense of touch at a specific region. Yes, so that is tactile agnosia, they will forget. Even though the sensory aspect is normal, motor aspect is normal, coordination is there, balance there, everything is there, then also they are not able to do, that is percept disorder. Spatial relation, figure ground discrimination, form discrimination, position in space, and topographical disorientation. So figure ground discrimination, keeping for the example of white towel on a white bed sheet, they will not be able to say if towel is there or not. Yes, boundary they are not able to get. Third is form discrimination, they will not be able to perceive the sense, what we know as stereognosis. Yes, they will lose the sense of stereognosis. Position space, where they are in the space, they will not know. Whenever you speak the words ahead of it, back of it, on the on, above, below, these words they will not be able to get it. And topographical disorientation, that is not able to sense a specific region or specific position. You ask the patient to move from room to hall in his own house, he will not be able to. Yes, it should be a known place, not an unknown place. If a patient is coming to you for 6 months therapy, he's coming to the same clinic and still does not know how to move from one region of the clinic to another region, when you specify, that is topographical disorientation. Cognition will have 5 sub-portions: alert, orientation, memory, executive function, and attention. We have discussed major portion, but we have not discussed executive function. We'll discuss about it. First, alertness. The patient should be completely alert. If he is not alert, his consciousness level itself will be low. Which are the types of consciousness level? We are going to discuss furthermore. Second, orientation. Orientation to TPP. Yes, time, place, and person. Remember, Orientation to time, what time of the day it is, not exact time, but morning, afternoon, evening, night. Place, which are the nearby places or where he is right now. The patient should be able to know if he's in the hospital, if he's at the home, if he's somewhere else. Yes, so that the patient should be aware. And last is person. So which are the relatives of that individual nearby. Yes, so he or she should be able to recognize his spouse, his children, his partner, his father, mother, whatever it is, relatives he should be able to recognize. And even you, if you are visiting him or her for the sixth or seventh time, say for example. Yes, so that is orientation to time, place and person. Memory, we have discussed immediate recall, short term memory and long term memory. Executive function, impulsiveness, inflexibility, decreased planning and impaired judgment. Yes, so all the four things. First is impulsiveness, how much the patient is impulsive. How will you know if a patient is impulsive or not? તમને કઈ રીતે ખબર પડશે પેશન્ટ ઇમ્પલ્સિવ છે કે નહીં? Yes, please unmute yourself. I'm not able to see your messages. I don't know why, but I'm not able to see it. What do you understand by term impulsive? Impulsive એટલે શું? This is not an exam. You can speak up yourself. It is fine completely. What do you understand by the term impulsive? General term. Yes, Fahim. Unmute yourself.
Yes, sir.
Yes, what is impulsive? What do you
Sir,
understand by the
if we
term
do
impulsive?
any act suddenly.
Okay. Hurriedly. Okay, fine. Okay.
Yes.
Vaishali. Unmute yourself. Vaishali Parhat. I guess we have two Vaishali in your batch, right?
Yes,
Unmute yourself. Yes, what do you understand by the term impulsive? Let's know.
sir, I guess अगर
Yes, go on. Okay, fine. So impulsive is nothing else but doing things without actually giving it a thought before. Yes, like in anger, you speak up many things. Yes, so that is an impulsive behavior. Yes. Next is inflexibility or rigidity of thoughts. Even though you ask the patient that you have to do this, if they have a different thinking than what you are going to do, then be rigid in his terms and he will not do it. Anyhow, whatever you try, how much ever you try, he will be inflexible or rigid in his thoughts. Yes. Third is disease decreased planning. So planning of activities is decreased. That is also part of cognition. Yes. The patient should not be doing activities because he cannot plan those activities. When you ask the patient to go drink a glass of water, if he does not have proper planning of what he has to do, he has to get up from the bed or the chair he's sitting in, then move around the whole, say for example his home or OPD, and go to the cooler, have a glass and then drink water and come back. So if this planning is not there, these steps are not followed, he cannot plan them. That is also part of executive function of the brain, that is cognition. And last is the impaired judgment. They cannot judge. Yes, judgment in the form of if it is right or wrong for him to do. Yes, so many people, many patients will be so mental they will tell you exercise will not do anything for me. Because of this thought, they will not perform exercises at all. Yes, and this is also an example of inflexibility or rigidity. Oftentimes it will happen, patient is brought on to the clinic or to the therapist by a relative. Yes, maybe his son, his father, whatever it is, he or she will bring to you. Yes, the patient will not come directly. Patient is not willing to exercises. They are completely rigid that this condition is permanent. They will not help me. Yes, a physical therapist or a neurologist will not be able to help me in any way. Yes, so they are rigid in that way, and because of this, they have a specific judgment for you or for the therapy. Yes, and because of this, the cognition is affected. Attention also sustained, selective, divided, and alternating. We have already discussed all the types, so we are not going into that detail. Emotional status we'll discuss. Yes. First is pseudo-bulbar effect. Pseudo means false, bulbar effect. Whenever your lower 4, 9, 10, 11, and 12 cranial nerves are affected, that is termed as bulbar. Yes, remember this. Bulbar effect, whenever we say it is lower 4 cranial nerves, 9, 10, 11, and 12. Here it is pseudo-bulbar effect. Pseudo means false. It has nothing to do with the bulbar effect. Why? Because it is pseudo. Yes, so here all cranial nerves will be normal, but whenever the patient is communicating with you, while enjoying or while even smiling, they will start crying, or opposite, while crying they start laughing. Yes, without any reason. That is utmost important. કોઈ પણ reason વગર patient વા માંડે or જોર જોરથી હસવા માંડે, that is termed as pseudo bulbar effect. Yes. Second is apathy. I guess everyone knows what is apathy. Anyone tell me? Apathy એટલે you know the term sympathy? Yes or no? Sympathy word સાંભળ્યો છે? Yes or no?
Yes, sir.
Yes. So what is sympathy and what is apathy? Sympathy એટલે you can explain in Gujarati, that is fine. Yes, Purva. Sympathy એટલે શું? What is sympathy?
સર સિમ્પથી મીન્સ ફિલિંગ્સ બે માણસ વચ્ચેની કે એવું કંઈક હોય.
Which type of feeling? That is what is more what we want to describe.
ભાવના.
Sorry, didn't get you, Purva.
Getting emotionally connected to someone. Like,
Okay. Yeah. A feeling of, you can being sorry or feeling the pain of an individual, that is what we call as sympathy. Apathy means lack of any type of sympathy for that individual. Yes, lack of interest. Okay, yeah, that is also true. Yes, so apathy is completely lack of sympathy. Yes. Euphoria, that is, you can say, the highest level of happiness. Yes, the patient becomes completely euphoric. Euphoric means completely. Depression. Why does depression happen in individuals? So persistent feeling of sadness and hopelessness. They do not see any hope. They are completely sad because of the condition itself. Second, they lose energy. So whenever you lose energy, they are using so much amount of energy. Now think of a stroke patient who has hemiplegia, one side is affected. They are performing exercises for months together. They are trying to achieve every single possible thing they can, but still they are lacking energy to perform it. Yes, so that becomes also a reason for depression. Inability to concentrate, because they have pain, they have different aspects, illnesses, and because of this they will not be able to concentrate on the exercises. Your goal will not be achieved, their goal will not be achieved to live a normal happy life. Decreased interest in life. Later on they give up all the hopes. We already discussed about the hopelessness. Yes, so they give a hope on the, they lose the hope in living also. Say they lose interest in the life also. Changes in the sleep pattern because of the medication, because of the therapy, because of the energy levels. There will be change in the sleep patterns. Generalized anxiety, they will be anxious at all times. They'll be rebellious at all times and will try to fight that I'm doing exercise all along. This, no, I'm not able to do this, I'm not able to do this. You, what are you doing? And they'll be anxious, they'll give you such thoughts. Yes, so you have to be aware how to manage anxiety for that individual also. Recurrent thoughts of death, yes, important aspect of suicide also. So they will always think of giving up their life because they have lost interest in life and do not have any hope. Yes. Okay, till here we discussed motor aspect, speech, perception, cognition, and emotional status. Anyone has any doubts? Yes or no? Everyone should unmute and tell me yes or no first. If it is yes, then I'll ask what's the question. I'm not able to read your chat. I don't know why. I'm not able to see who is present or not. So unmute yourself. If you have doubt, speak up. And if you don't have doubt, unmute yourself and say no.
No, sir.
Everyone.
No, sir.
No,
sir.
no, sir.
No,
No,
sir.
sir.
No,
No,
sir.
sir.
No,
No,
sir.
sir.
No, sir.
No, sir.
Okay, okay. Fine. Purva, have you taken the attendance?